Okay. So thank you for inviting me in this session. In this presentation, I will try to summarize a broad topic, which is the management of type 2 diabetes with GLP-1 RAs. So to make this presentation a bit more relevant to everyday clinical practice, let's consider a typical outpatient with type 2 diabetes that many of practicing clinicians encounter in their daily practice. So let's suppose that our patient is a 60-year-old male, Mr. JD, who has come to our clinic with concerns about managing his type 2 diabetes and his weight gain. He was diagnosed with type 2 diabetes about approximately 2 years ago. He has been on metformin monotherapy since then, and his current HbA1c, let's say it's about 7.2. It is also worth noting that Mr. JD has experienced an ischemic stroke approximately 1 year ago. Also, one of his major concerns is his inability to lose weight, despite having tried several diets. And he's concerned that this weight issue is related to his suboptimal diabetes management. So let's explore some of the treatment options we could consider for this patient. His HbA1c is 7.2, which suggests that metformin alone is probably not quite effective for controlling his diabetes. Also, given his history of ischemic stroke, cardiovascular risk is also a factor that we have to address in this patient. So what would be the optimal decision regarding glucose-lowering treatment in this patient? Should we increase the dose of metformin? Should we replace metformin with another medication? Or could we add another medication to metformin? To decide, it's important to consider some important facts about this patient, not only his need for better glycemic control, but perhaps more importantly, his cardiovascular risk history, and also his concerns about weight gain. Let's see what the latest ADA in a 2023 treatment algorithm for type 2 diabetes suggests for such a case. According to this algorithm, for patients with history of atherosclerotic cardiovascular disease, which includes stroke in its definition, alongside coronary artery disease and peripheral artery disease, the recommendation in these patients is to consider treatment with either a GLP-1 receptor agonist with proven benefit or an SGLT2 inhibitor with proven cardiovascular benefit. It's also noteworthy that this recommendation holds irrespective of the background anti-diabetic treatment of a patient or the current state of their glycemic control, their HbA1c level. Furthermore, if weight reduction, as you can see in the right side of this slide, is one of treatment goals, as it is the case in this particular patient, GLP-1 arrays are also prioritized, and in particular semaglutide, first of all, followed by dulaglutide and liraglutide. Also, tirzepatide is a first-line option alongside semaglutide. But why does this recommendation hold? Why GLP-1 receptor agonists specifically are recommended for patients with atherosclerotic cardiovascular disease? The reason for this lies in the cardiovascular benefits that some of the GLP-1 arrays have shown in cardiovascular outcome trials, in addition, of course, to their glucose-lowering potential. In particular, several of these agents have demonstrated a reduction in MACE in major cardiovascular events, making them an attractive option for such patients. In fact, this is a screenshot for a meta-analysis of cardiovascular outcome trials with GLP-1 arrays. When all these trials were pulled in this meta-analysis as a drug class, GLP-1 arrays reduced the composite outcome of major adverse cardiovascular events, MACE, which includes stroke, myocardial infarction, and cardiovascular death. And also, it's important to note that a numerical benefit, which is indicated by this square being in the left side of the vertical line, was shown in all GLP-1 arrays except for lixisenatide in the ELIXA trial. Furthermore, when looking at the individual components of MACE, GLP-1 arrays also were effective in reducing cardiovascular death by 13%, as well as reducing myocardial infarction by 10% and stroke by 17%. Among these three components of MACE, perhaps the most impressive effect was the 17% reduction in stroke, which is particularly relevant to our patient, Mr. JD, who I remind you that has a recent history of ischemic stroke. GLP-1 arrays also reduced all-cause mortality and, to some extent, hospitalization for heart failure. However, for the later outcome, for the hospitalization of heart failure, it's important to interpret this finding with a caution, because this effect was marginally statistically significant and was primarily driven by two specific trials, Harmony and Amplitude, which are for drugs that are not currently used or approved for use in clinical practice. With regard to kidney outcomes, GLP-1 arrays also reduced the composite kidney outcome, which includes microalbuminuria and some other outcomes like doubling of serum creatinine, but also hard clinical outcomes like kidney replacement therapy or death from kidney disease. Again, it's important to highlight that this effect was primarily driven by the effect of GLP-1 arrays on reducing macroalbuminuria and not the hard clinical outcomes, kidney outcomes, such as kidney replacement therapy of death from death from kidney disease. Up to this point, I have been discussing the impact of GLP-1 arrays based on these randomized controlled trials, the cardiovascular outcome trials. However, it is equally important to look for this effect at real-world data to validate the effects of these cardiovascular outcome trials. In this context, this is a meta-analysis of observational real-world studies, mainly retrospective cohort studies from large health registries. And as shown in this slide, the results from this meta-analysis corroborate the beneficial effects of GLP-1 arrays on these cardiovascular outcomes like MACE, all-cause mortality, myocardial infarction, and stroke, versus when compared with other glucose-lowering drugs. This is a real-world data, so the comparator cannot be placebo here, as in the randomized controlled trials, the cardiovascular outcome trials. It is also important to note that in this meta-analysis, SGLT2 inhibitors were not included as a comparator in the other glucose-lowering drugs. And now, a reasonable question that you may be asking at this point is why choose a GLP-1 array and not an SGLT2 inhibitor, especially given that cardiovascular outcomes with SGLT2 inhibitors also showed a beneficial effect on cardiovascular outcomes. Even more so, the recent ADA treatment algorithm also recommends SGLT2 inhibitors alongside GLP-1 arrays, of course, provided these individual drugs have shown a cardiovascular benefit. Related to this comparison between GLP-1 arrays versus SGLT2 inhibitors, this is a recent network meta-analysis of cardiovascular outcome trials, which indirectly compared the GLP-1 arrays versus SGLT2 inhibitors, and in most outcomes found no significant difference between the two drug classes in MACE, myocardial infarction, cardiovascular death or stroke. However, GLP-1, regarding stroke, GLP-1 arrays showed a trend to be slightly more effective than SGLT2 inhibitors in reducing stroke. However, this effect was marginally not statistically significant. Also, SGLT2 inhibitors were superior versus GLP-1 arrays in reducing the composite renal outcome and heart failure hospitalization. Now, regarding stroke, which probably GLP-1 arrays have a benefit or a more profound beneficial effect as SGLT2 inhibitors do, it is interesting to note that the latest treatment algorithm from the American Association of Clinical Endocrinologists guidelines prioritizes GLP-1 arrays in patients with a history of stroke or transient ischemic attack. And the rationale for doing so is that GLP-1 arrays, and particularly prioritizes among GLP-1 arrays two substances, semaglutide and dulaglutide. And the reason for this is most likely that these two drugs, dulaglutide and semaglutide, had the most impressive effect in reducing non-fatal stroke, as shown in this meta-analysis. Also, regarding fatal stroke, GLP-1 arrays as a drug class had a beneficial point effect estimate, reducing it by 20%. But again, this effect was marginally not statistically significant, but the lack of statistical significance in this case could probably partly attributed to the small number of events of fatal stroke compared to the number of events for non-fatal stroke. There have been various hypotheses that have been suggested for this beneficial effect of GLP-1 arrays on stroke. These can be broadly categorized in two themes. One theme has to do with mechanisms that result in increased neuroprotection, such as reducing cerebral inflammation, inhibiting nerve cell apoptosis, or enhancing synaptic plasticity, etc., and other mechanisms. And the other set of theories suggests that GLP-1 arrays may directly or indirectly, through different mechanisms, reduce cerebrovascular atherosclerosis, which is the leading cause, of course, of ischemic stroke. In addition to their effects in cerebrovascular and cardiovascular outcomes, there is also another advantage of GLP-1 arrays that you have also heard in previous lectures today, which is particularly relevant to our specific individual patient in our case scenario, which is their role in weight management. In fact, the ADA 2023 treatment algorithm, specifically, as I have already mentioned, GLP-1 arrays and tirzepatide, when goal weight gain is an important management goal in a particular patient. In fact, this is a large network meta-analysis from our team, in which we included more than 400 RCTs, and was published 2 years ago in 2021, where we found that semaglutide, subcutaneous particularly semaglutide, was by far the most effective glucose-lowering medication for reducing body weight. In the previous lecture, you have seen a similar network meta-analysis from our team regarding the effect and the superiority also of semaglutide, subcutaneous semaglutide in reducing HbA1c. An important note that you may want to have in mind is that in this meta-analysis, we did not include tirzepatide, which was developed later and has shown an even more impressive effect both in reducing HbA1c and body weight compared to subcutaneous semaglutide. Another clinical question related to our case scenario is whether our decision to start a GLP-1 receptor agonist in this patient should be affected by his current glycemic control or the fact that he's already taking metformin. As I have already briefly mentioned, the ADA currently recommends that treatment with drugs with cardiovascular benefits such as GLP-1 RAs or SGLT2 inhibitors should be prioritized in all patients with type 2 diabetes and atherosclerotic cardiovascular disease, irrespective of their HbA1c value or their background glucose-lowering therapy, including metformin. And this recommendation is not supported only by the ADA, but actually from all organizations, almost all organizations, NICE is an exception, such as the European Society of Cardiology, which also has issued the same recommendations, independently of glucose control and background anti-diabetic medications. These issues have also been addressed in subgroup meta-analysis of cardiovascular outcome trials, such as the one shown here, in which the PEFOR interaction value, which is a statistical value that compares the two groups, subgroups. In this case, the two subgroups are patients with high baseline HbA1c and patients with low HbA1c from cardiovascular outcome trials. And this value was non-significant, which indicates that the beneficial effect of GLP-1 receptor agonists on MACE is independent of whether the patient has high or low HbA1c at baseline. Of course, the definition of high and low HbA1c was not consistent in all cardiovascular outcomes, but approximately the threshold for between high and low was 8% of HbA1c value. In a similar manner, another subgroup meta-analysis, this time from our team, suggested that the favorable effect of GLP-1 arrays on MACE was evident both in patients already on metformin and those who were not taking metformin as background therapy. Okay, up to now, based on this information that I have shown, a GLP-1 array seems to be an optimal treatment option for our patient who has a history of stroke, who needs some better glycemic control, and also who is obese and wants to lose weight. However, let's change a bit this clinical scenario, and let's suppose that our patient did not actually have a history of stroke or other established cardiovascular disease, but he has solely cardiovascular risk factors for cardiovascular disease, such as dyslipidemia, old age, and hypertension. In other words, he has solely multiple cardiovascular risk factors and not established cardiovascular disease. Would GLP-1 array still be the preferable treatment option in this patient? Or to rephrase this question in more research terms, does the favorable treatment effect of GLP-1 arrays on MACE differ between patients with established cardiovascular disease and patients without cardiovascular disease but with cardiovascular risk factors alone? On this subject, in the ADA algorithm, GLP-1 arrays are recommended for such patients in the similar manner that they are recommended for patients with established atherosclerotic cardiovascular disease. The recommendation does not change. Let's go into some more details on this subject and see what research evidence has to say on this matter. This is a meta-analysis from our team that has recently been accepted for publication in a journal. And in this forest plot, we did a subgroup meta-analysis of GLP-1 arrays cardiovascular outcome trials on MACE, with one subgroup being patients with established cardiovascular disease, and the other subgroup being patients without established cardiovascular disease, but with cardiovascular risk factors alone. According to the current methodological guidance on how to interpret subgroup analysis, and meta-analysis, given that the pay-for interaction value for this subgroup effect was below 0.1, which is considered now the threshold value for statistical significance in subgroup analysis, contrary to the conventional value of 0.05 in regular analysis. We had to proceed to use a specific tool to interpret subgroup analysis, which is called Iceman tool, and was recently published by the methodological group in McMaster University. In fact, this tool, Iceman tool, the aim of this tool is to interpret the subgroup meta-analysis and decide whether it's more reasonable to use the overall estimate for both subgroups or use the individual estimate for each subgroup separately. So this is the 9 criteria of the Iceman. We assessed this analysis based on this criteria, and finally, we decided how credible this potential subgroup effect is between subgroups. And when I say subgroup effect, I mean that there is a difference in the beneficial effect between patients with established disease and those without established cardiovascular disease. And the Iceman assessment suggested that this effect has low credibility, which means it's more reasonable in this case to use the overall relative effect estimate, this effect estimate, for both subgroups, which means that irrespective of presence of atherosclerotic cardiovascular disease, GLP-1 arrays in average reduce MACE by 15% with a hazard ratio of 0.85. Well, meta-analyses are, of course, good and the findings are useful, but how are these findings from meta-analysis and research, for example, a hazard ratio of 0.85, can be interpreted in more lay language in clinical practice? In other terms, what is the absolute treatment effect in absolute terms of GLP-1 arrays in reducing cardiovascular outcomes in our particular patient? Well, as we already said, even the same hazard ratio of 0.85 can be applied to both patients with established cardiovascular disease and those with cardiovascular risk factors. The absolute benefits in these different subpopulations are not the same. And this is because a patient with established cardiovascular disease has a higher background probability to have a cardiovascular event in the future compared with a patient with solely cardiovascular risk factors. And so the absolute benefits, the potential absolute benefits of GLP-1 arrays are expected to be larger, more pronounced in patients at higher cardiovascular risk and those with established cardiovascular disease. To quantify this absolute risk in both subgroups, we applied the baseline cardiovascular risk of each subgroup to the hazard ratio as produced from the meta-analysis on MACE, using a free software, GetPro-GDT, to calculate 5-year absolute treatment effects in both subgroups of patients when treated with GLP-1 receptor agonists. And the result was that in patients with established cardiovascular disease, the absolute benefits were 2-fold higher than in patients with cardiovascular risk factors alone. Just a methodological note, in this analysis, we calculated baseline cardiovascular risk based on the MACE incident in the placebo arm of cardiovascular outcome trials, which were included in the analysis. Alternatively, perhaps a better and more patient-tailored way to do this is to use a patient-specific cardiovascular risk using a prediction model such as like the SCORE2 diabetes model, which you have seen in the previous lecture. In brief, this model was published a couple of months ago, and it can estimate a 10-year cardiovascular risk of an individual with type 2 diabetes based on 10 parameters. Its main advantage on previous prediction cardiovascular models is that it focuses exclusively on patients with type 2 diabetes. Perhaps its disadvantage is that it's applicable mainly to European populations because it was developed based on data only from European countries. So, having reviewed all this information, we feel confident that we can prescribe a GLP-1 receptor agonist to help this patient reduce his cardiovascular risk and also help him to lose weight, which is one of his main concerns. However, before we proceed to prescribe a GLP-1 array, Mr. JD tells us that confesses about his financial problems and says that he will not be able to afford the pocket costs of a new GLP-1 array because these medications are too expensive for him. Related to this issue, a number of studies that were mostly conducted in the United States of America have found that in real-world practice, GLP-1 arrays are actually underused in minorities and socioeconomically deprived patients with type 2 diabetes, which includes patients with low income, for example, or patients with low education level, compared to patients with higher socioeconomic status. And among other factors, a key contributor to this disparity is the inability of many people with lower socioeconomic status and low income to afford actually these expensive drugs. And this effect is more pronounced in countries such as USA, which does not cover the medications cost for many uninsured patients. An important strategy to mitigate this inequality would be for governments to advocate for a reduction in the price of costly GLP-1 arrays when negotiating drug prices with pharmaceutical companies. This would not only make these medications more affordable to individual patients, but would also help the government itself by making the medication more cost-effective at a societal level. In fact, related to this issue, a number of cost-effective analyses suggest that in many countries, ranging from low-income countries to medium and high-income countries, GLP-1 arrays were found to be not cost-effective compared to other antidiabetic medications, including SGLT2 inhibitors. And perhaps the most striking example is the United Kingdom, where the recent NICE guidelines for treatment of type 2 diabetes do not include GLP-1 arrays in their treatment algorithm because they clearly state that they are not considered to be cost-effective. So, in conclusion, a summary, perhaps take-home message from this presentation is that indeed, GLP-1 arrays do have proven advantages over other medications and can be the optimal treatment in many cases for people with type 2 diabetes with high cardiovascular risk or who are obese. However, real-world data suggests that in many cases, these medications may not reach all those patients who need them the most, and high cost seems to be one reason contributing to this inequality. Thank you.